So I want to welcome everyone to our virtual student presentations at ATS or SPATS session. My name is Allison Light Mills. I am a staff scientist for the University of Rochester Pulmonary Hypertension Program. I'm also a proud MIT committee member. I'm going on my third year, so it's pretty exciting. And I'm going to be your moderator for tonight's SPATS session. So we're delighted to have everyone here today to learn about the important work of our student scholars using the 3-minute thesis format. And while it would have been great to see everybody present in person at ATS, we're just grateful that we could all still come together virtually despite everything going on. So thank you all for working with the MIT committee to make this happen. So the 3-minute thesis format was developed by the University of Queensland. It's an academic competition that challenges students to describe their research within 3 minutes to a general audience. The 3-minute thesis celebrates the discoveries made by research students and encourages their skill in communicating the importance of research to the broader community. And so immediately prior to the session, I actually just reviewed the criteria and rules with our judges. So I just have a few quick reminders for everybody else today before we get started. First, the presentations are limited to 3 minutes, and I will be timing each presenter, and I will interrupt you if you exceed that time limit. After each presentation, we're going to open up the floor to the judges and invite any comments or feedback they may have. And then once all the presentations have concluded, we'll be posting a link in the chat box for what's called the People's Choice Vote. So you can vote for the presentation that you found the most compelling. So make sure as you're listening, you think about which presenter you enjoyed the most so that when we're all done, you can register your vote for People's Choice. At the very end of the session, we're going to announce the top 3 winners based on the judges' scores, and we'll also reveal the People's Choice results. So we'll want you to stick around to the end to kind of see the results of today's presentations. So tonight we have 3 wonderful judges. We've got Bashar Staitia, who is an assistant professor in pulmonary at Emory. We have Jillian Gooby. She's a research fellow at the University of British Columbia and a PhD student at the University of Pittsburgh. Our third judge is Joe Hippensteel. He's an instructor for pulmonary sciences and critical care at the University of Colorado. So welcome judges, and thank you all for being with us for this event today. We're really, we greatly appreciate the time that you're putting into this session for us. Lastly, before we get started, I just want to introduce Greg Downey, President-elect, who's going to share a few words with you all now.
Well, first of all, thank you for giving me the opportunity, and I want to welcome you all to this virtual session and to the ATS. It wasn't very long ago, at least it seems in my mind, that I was in your position, and I really think that my relationship with the ATS, which began many decades ago, changed my life. So I welcome you to a community that is inspiring and will serve you well throughout your career. I also just wanted to make a very brief comment about the turbulent times that we're living in. And one of the sort of spin-offs of that is that we have to have our meetings virtually, which is hard on us all, but I want to acknowledge the incredibly hard work of the ATS staff who has made all this possible. In my career, I've seen many infectious diseases rise and subside. Polio, when I was very early in my career, HIV/AIDS, numerous strains of influenza, SARS-1, and now the SARS-CoV-2. And I want to reassure you that we will get through this. In a year or two, we will be on the other side and we will have learned a lot. Hopefully, the powers that be in Washington will come to their senses and coordinate this. But I think that you are joining the ATS in a time of need of respiratory scientists and physicians, and I welcome you. Thank you.
Thank you so much, Greg. We appreciate those words. I just want to remind all the speakers that as I introduce you to please make sure your video is on so we can see you speaking. I'll be displaying your slides for you. I'll introduce each speaker before they start. Just correct me if I happen to make any mistakes about the name or institution or anything. So is everybody ready? Everybody's wearing pants. We can all start? Okay. I'm going to get my screen share ready, and then I'm going to introduce our first speaker for tonight's session.
Or this morning's session, depending on where you are.
True story. Sorry about that. Okay, so can everybody see the slide? I just want to confirm. for screen sharing. Okay, so our first speaker for tonight is Daniel Mai at the Eastern Virginia Medical School in Norfolk, Virginia. Daniel, whenever you're ready to start, you can start.
Can everyone hear me?
Yes.
Oh, perfect. Okay. Hey all, my name is Daniel Mai, and my project specifically focuses on how transcription factors respond to shear stress by interacting with one another to remodel the chromatin landscape, and then open it to allow transcription of genes involved in inflammation. So we'll just quickly define shear stress as the force that acts upon a surface, and for the purposes of our discussion, there are two types. There's laminar shear stress that I'll abbreviate as LSS, and you'll see this at straight parts of vessels with constant streamlined flow. And then you'll have disturbed shear stress where there's stress at sites of vessel branching or curvature with more turbulent flow that's more likely to prevent stress and inflammation. For our transcription factors, we have the SWE/SNF family, which stands for switch sucrose non-fermentable, which has nucleosome remodeling function and is involved in cardiomyocyte repair. It consists of multiple central catalytic subunits such as BERG1 and other supplementary units such as BAF170. And then on the other hand, we have AP1 or activator protein 1, which has been well documented in the literature to play a role in inflammation by driving cytokine production, cell stress. And it consists of CFOS, c-gene, as well as some activating transcription factors such as ATF2, ATF3. So putting all of this together, on the top of our screen, we have a working model that I put together where under disturbed shear stress conditions, AP1 and SWE/SNF may interact with one another to open up the chromatin landscape in the nucleus and allow transcription of genes involved in vascular inflammation. To test this, I first cultured endothelial cells under LSS and DSS conditions. I'm using a flow system and visualize them under microscopy to ensure linear alignment if it was LSS, and then disorganized alignment if it was under DSS conditions. Next, I used a pretty cool technique called a proximity ligation assay, where if our proteins of interest were in proximity of each other, then they would be detected by a primary antibody, which would then be detected by a secondary antibody, and then rolling DNA synthesis would occur for a fluorescent probe to occur. And you would see this fluorescent signal. Combining this with confocal microscopy, where you capture different depths of a cell and then create a 3D rendering or a Z-stack, you could then detect that the signal is indeed within the nucleus. So as you can see in the bottom right of the screen, under the DSS conditions exclusively, there are multiple punctate fluorescent signals between BERG1 and BAF170 of the SWE/SNF family and ATF2 of the AP1 family, and not under LSS conditions. So what I can conclude is that DSS promotes nuclear co-localization of SWE/SNF and AP1, which may be a possible mechanism to drive vascular inflammation. Thank you.
Great, thank you, Daniel. The sound was a little scratchy, but
Sorry.
no, that's okay. I hopefully, but it was great, and I love that your slide's very visually appealing. So I'm going to turn it over now to the judges and invite any comments they may have about your presentation. Go ahead, judges.
Daniel, I want to say a really great job. My question for you is, tell me about what disease states you think this is particularly relevant to.
Yeah, so what we were super interested in was pulmonary arterial hypertension and the development specifically within, we were using my studies and also trying to study in the realm of pediatric cardiology for congenital individuals who are more prone to developing pulmonary arterial hypertension.
And I'll jump in and offer a comment if I'm properly unmuted here. I think I am. Good. So I was going to say first, I like the slide. I think you did a nice job picking some images that would be dramatically emphasizing your point. And I think that's a key thing when you've just got one slide to kind of make a big impact with. And so I can see what you're talking about here from the results standpoint. I think integrating your sort of schema here with the results is also very helpful. So I like that as well. And I think framing is important when you're in a situation like this. So doing something to, give us the clinical context up front so we know exactly what you're going after. I think just to orient people more than anything else, it's clear which pathways you're working on. And, these are pathways that are important in a lot of different diseases. And I think if you if you just sort of get everybody's head in the space that you're talking about right out of the gate, I think that'd be helpful. But I think, you have a good speaking style. You clearly know your material. You're, using your hand gestures to emphasize important points. And I think all of that got your message across clearly. So nice job.
Thank you.
I would also say excellent slides, echoing what the other judges said. And I think that your presentation was quite clear. So good work.
Thank you.
Okay, great. Let's move on to the next speaker. Just going to advance the slide, hopefully. Okay. So our next speaker for tonight is Nicole Robertson at the University of Kentucky College of Medicine in Lexington, Kentucky. Nicole, are you here?
I am.
Okay, great. So whenever you're ready.
I'm going to ask you to hold your breath while I tell a short story. Okay, take your last breath and hold. As I interviewed community members with COPD in rural Uganda, a man told me, "The disease I'm suffering from is suffocating." While another woman told me, "The disease really got worse. I got cough and I coughed for a long time. I used to cough and I felt I was suffocating." I saw that individuals were suffering from the effects of COPD due to tobacco smoking, occupational exposure, and most importantly, cooking over fires while burning biomass. More than 90% of COPD deaths occur in low and middle income countries. Okay, you can take a breath now. This is a mere representation of what people with COPD experience daily. My research focuses on these culturally appropriate, as you can see in the slide, educational action plans for community health workers to teach community members with COPD how to self-manage their COPD. In low and middle income country settings, community health workers are chosen and elected by their community as vital players within the healthcare system to provide health education and health information. Through our trial in Uganda, Nepal, and Peru, community health workers utilize this action plan to provide regular one-on-one instruction on behaviors preventing COPD exacerbations and managing their medications, such as breathing exercises, smoking cessation, ventilating their cooking spaces, and picking up healthy eating habits. Published literature has shown patients that know how to self-manage their condition have better COPD health outcomes. To test the COPD knowledge change from before and immediately after educational intervention, we developed a 12-item validated and reliable COPD knowledge questionnaire to test this. We found that before education, the average score was 7.9 points out of 12, and then immediately after education, it was 9.7 points out of 12. The proportion of individuals scoring over 80% accuracy, which we deemed as passing, increased from 30% of participants to 67% of participants. Therefore, our findings show that COPD education has increased knowledge among individuals with COPD. We hope that knowledge is power, and strengthening community health workers to provide health education can help the 251 million people worldwide with COPD. Thank you.
Okay, thank you so much, Nicole. A very intriguing intro. I really enjoyed it. Judges, floor is yours.
Do you want to go first, Jillian?
Nicole, I thought that was a very well done presentation. Sorry, my Wi-Fi is a little bit laggy, so I might interrupt people here. But I really like your intro. I think your speaking cadence is excellent. I think that the flow of your slide here makes logical sense. The one thing that I would say about the visual presentation is that I'm not entirely sure what's on this pamphlet here, and I would like to actually be able to see a little bit more about what the words are on there, so that I get a little bit more context of exactly the sort of questions that you were trying to ask and knowledge base that you were trying to assess for these individuals. But I think excellent work and very important.
Okay, thank you.
And I'll jump in next. I thought you did a really nice job. I am a little bit concerned just because I was not able to hold my breath for the duration of your intro, and now I'm worried, but that's a conversation for another time. But no, I like the intro that I think leading with the fact that these people feel like they're suffocating is important, and it's a great way to grab people's attention, because honestly, it can be a little desensitizing dealing with these sorts of problems day in and day out, and we forget that, you know, we're trying to help folks who can't breathe. And so you really highlighted that nicely. I like the slide progression here. I agree that, you know, it'd be nice to know what's on the pamphlet. I think you explained it well, but I think, you know, if you had maybe zoomed into one portion to give us a sense of the kind of thing you were looking at. The only other comment I have for you in terms of constructive feedback is when you have a slide like this that's clearly trying to convey a big picture of what you're working on, and I think did that very nicely, when you get into the granular details of your results, it can be a little bit hard to process. So when you said, you know, we moved from 9.7 here to here, I think if you had been able to work in, or if you had, you know, rejiggered things just a little bit, so you could have given us a little bit of a, you know, a graphic that showed us exactly what you're seeing, or exactly what your results were, in some manner that would have not had me trying to remember the decimals in my head, because I was still hung up on not holding my breath. But otherwise, I think you spoke well. I think you clearly know your material. You care about this a lot. And I think the way you structured things made it very impactful. So nice work.
Thank you.
Awesome. So awesome job all around. I think I love the passion. Obviously, the script you put together was great to give us a sense for how much you care about what you're doing, which I think is most important. And for where you are at in your life, I think you're right on track to be a great pulmonologist, or whatever you decide to do, a respiratory therapist, whatever the course may be. I would echo Bashar. I think the fourth panel could be basically your results, you know, and I think that would have been pretty cool to say we improved outcomes by this much. And I think whenever I see slides, I'm like a very simple slide presenter. I want one data point per slide and no more, because otherwise I get lost and I can't actually pay attention. So if you have one data point at the end here, I think you really hit home that you had a really effective intervention. But I think really nice job all around.
Thank you.
Great, thank you, Nicole and the judges. We'll move on to our next speaker. Okay, so next up we have Sophia Levant, the University of California in San Francisco, California. Sophia, whenever you're ready to start, go ahead.
All right, let me get myself unmuted.
Yeah, you're fine, take your time. Timer doesn't start until you speak, so.
Right. So who remembers elementary school? I want everyone to actually picture their elementary school and think about the kids in their class. Specifically that one kid who was allergic to everything. The one who had an EpiPen and an inhaler because they were not only allergic to shellfish and tree nuts, but also had asthma. I want you to raise your hand if you know a kid like that. In fact, maybe you were that kid. There's one in every class. And in mine, her name was Chloe. And I actually spent my entire PhD trying to figure out what made Chloe different from all the other kids in the first grade. Because while asthma is the most common chronic disease, there are three things that are a little different about kids like Chloe. One, they don't just have asthma. They actually have multiple allergies to everything from peanuts to tree nuts. Two, they're becoming more common. And three, most children like Chloe suffer from allergies and asthma for the rest of their lives, which places an enormous burden not only on these children and their families, but also on the entire healthcare system. So our goal is to prevent asthma. But to do this, we need to understand what makes kids like Chloe different from the other kids in the first grade. And to answer that question, we looked at baby poop. And that may be surprising, but what you need to know is that baby poop, like all other poop, is full of bacteria and fungi. And that the community of bacteria and fungi that live in and on your body is known as your microbiome. In your intestines, your gut microbiome acts like a tiny chemical factory, pumping out a sea of chemicals. And when we examined baby poop, we found that the gut microbiomes of babies who go on to develop allergies and asthma look different. They have different bacteria and fungi, and their tiny chemical factories make a ton of one chemical in particular, a linoleic acid known as 12,13-dihome. And when we treat mice with this chemical and expose them to allergens, their lungs become irritated and inflamed, and they actually look like the lungs of children with asthma. And And this is fascinating. So we actually dug deeper and used metagenomic sequencing and found that among the thousands of types of bacteria and fungi in baby poop, only 3 have the machinery to make 12-13-dihome. Even more exciting is that if you treat mice with these genes and linoleic acid, a fat found in breast milk and formula, the concentration of 12-13-dihome in their blood goes up. And when you challenge them with allergens, their lungs become irritated and inflamed and mimic those of children with asthma, which actually means we could walk through a nursery and collect baby poop and measure the concentration of this chemical or the genes that produce it and predict which children will grow up into kids like Chloe. So to test our hypothesis, we did just that. We took baby poop from 2 groups of 1-month-old babies in 2 different cities and showed that babies with more 12-13-dihome or more copies of the bacterial genes that make it are more likely to develop allergies and asthma in childhood. And while this is a long way from preventing disease, accurately identifying babies years before they develop asthma gives us a place to start.
Okay, time is up. That's perfect timing. You're done. Okay, thank you so much for a very energetic presentation and a very creative slide. I'm going to hand it over to the judges for their input now.
All right, I think I unmuted myself first. I'll go ahead. So very nice job. I really liked your speaking style. I think you did a really nice job emphasizing particular words and sort of keeping things punchy. This is, obviously not the ideal format for making a passionate case for your research when you don't have, like a live presence to really captivate your audience. But you did a really nice job keeping things punchy and kind of, keeping interest focused on what you were talking about. It turns out I learned from your presentation I can hold my breath for longer than I thought, but only when I'm thinking about elementary school. So thank you for that. That was a nice introduction, and I absolutely knew one of those kids as well. In terms of the information, the content, I think you got your results out nicely. I very clearly understood what you did, what you found, and why it's important. And I think you conveyed that very clearly. On the slide, I guess I knew where you were heading because I could sort of see from your graphic here right up front, but I didn't have anywhere for my eye to go with the slide right out of the gate. I think while you were doing your introduction, I was sort of, looking at it and listening to you, but there was nothing for me to kind of hang on to visually up front. So it's not that I don't like the design. I do. I think you did a nice job. It's rare that you can kind of get away with a chemical formula and still make it relatable, but I think you did that well. I just think if you had maybe had some sort of flow or progression on the slide that I could kind of walk through with you while you were speaking, I think that would maybe emphasize your early points with some more, let's say, visual flair. But I think you did a very nice job, and you're clearly a very good speaker, so good work.
Thank you.
I might jump in here. So, Sophia, I thought you did an excellent job. Again, echoing that your presentation style is great. I want you to keep that up. I thought that you did a great job at highlighting the burden of childhood allergies and asthma, because that's something that's really important for us to continue researching, and early identification is very important, as you help to emphasize. I would caution you with some jargon if we're trying to have a more layperson audience. I think you said metagenomic sequencing at one point, which might be a little bit difficult for people who are coming from a lay perspective to understand. And then one thing that I would say you could add to the slide to just kind of bring it home a little bit more would be to add a little bit of something about your results, because it seemed as though your results were quite impactful, and I would like to see something in the slide that kind of addresses that. But great job.
And I'll just do a quick 10-second, 15-second thoughts. I think really wonderful work. It's clear that you did a lot of cool science to come to these conclusions. And I agree. I think just throwing in a little bit to include your results here would be very helpful for us. I think you described it really well, and I'd be really excited to see the full PowerPoint presentation. So good job.
Okay, great, thanks. So we're moving right along. We're gonna go to our next speaker. So let me just advance the slide. Okay, so next up we have Diego Alexi Tovar Giombini from the Istituto Politécnico Nacional in Miguel Hidalgo, Mexico. Diego, whenever you're ready.
Thank you. Hello, thank you all for being here, and thanks to the American Thoracic Society for the opportunity to talk and share our work with you. Well, the study of pneumonia is very important because it is the only communicable disease among the top 5 causes of death in the world. Staph aureus is described as an uncommon pathogen in community-acquired pneumonia. Approximately for 2% of hospitalized adult patients with CAP. Staph aureus pneumonia can be severe and can result in lung necrosis, respiratory failure, acute respiratory distress syndrome, and NPM and bacteremia. However, the great majority of studies are largely focused on methicillin-resistant Staph aureus. Nowadays, the epidemiology of Staph aureus infection is changing, with a decline of infection of MRSA and an increase of infection caused by methicillin-susceptible Staph aureus. Finally, there is little information about the prevalence, risk factors, and clinical features of CAP caused by MSSA. And what did we do? We performed an observational cohort study of consecutive patients admitted to the Hospital Clinic of Barcelona between January 2004 and December 2018 with a diagnosis of CAP. Staph aureus pneumonia was defined as a pneumonia with an isolation of Staph aureus in blood cultures or in a valid respiratory sample. The demographic variables, comorbidities, and physiologic parameters were collected in the emergency room within the 24 hours of admission. And what did we find? First, the prevalence of CAP due to MSSA was 1% of all CAP cases, and 4% of CAP with a defined microbial etiology. The prevalence of MSSA CAP in our study was comparable to that found in previous studies. The CAP caused by MSSA have similar outcomes compared to CAP caused by MRSA, but we identified several risk factors associated with CAP caused by MSSA. That was female sex, diabetes mellitus, and a previous episode of pneumonia. The mortality among MSSA CAP patients was not different than that of MRSA CAP patient. Even the multivariate analysis did not find any association of MSSA infection with patient's outcome. In the analysis of 30-day mortality, we found that chronic renal diseases, neurological diseases, lymphopenia, and ARDS were associated with an increased risk of 30-day mortality in patients with Staph aureus CAP. On the other hand, the fact that lymphopenia was a risk factor for mortality confirmed.
I'm going to have to cut you off. We're at 3 minutes.
Okay.
Thank you so much, Diego. I will let the judges give some feedback.
I'll speak first. Diego, I think really nice job. Good work with this big cohort of patients. I think that there's a logical sequence to what you went through, and I think your arrows sort of lay this out to some degree. And I think it would be helpful for me to have a little bit more information on this slide. I think this is always sort of that razor edge that you're walking with these research presentations that have limited space. But maybe knowing some specific numbers and sort of categorizing down in this bottom right what the female sex and diabetes and then CKD, ARDS, et cetera, sort of point to would have been helpful for me. But I think really phenomenal job overall with your work, and trudge ahead.
Thank you.
Oh, sorry. So I thought that you did a great job, Diego. I thought your presentation was really clear. You did a good job of emphasizing the importance of the issue and the global significance. And I think that that is something that you could potentially highlight a little bit more on the slide, just to draw attention to how big of a problem it is, which is what you drew attention to when you were speaking. And I liked that you kind of displayed the risk factors associated with adverse outcomes. But I believe in your bottom right corner of the slide that I got a little bit confused about exactly what the diabetes, female gender, and then different comorbidities was exactly referring to. So maybe a little bit more signposting about what those are specifically referring to in your outcomes.
Okay, thank you.
Great job.
And there we go. I think I got it. Okay. So very nice job. You know your study well. You did a great job talking us through it. And I think you followed a very logical sequence in how you presented things. Just a few thoughts for you on the slide. I really liked the top right and how you sort of drill things down and really made it clear exactly what you did and what the percentage of each patient's grouping was. I think that's super helpful. Some of the other areas that my colleague judges here have emphasized, I think you might have been able to free up some space by removing some of the images that maybe didn't tell any part of the research story per se. I don't know what you were going to refer to later on in the bottom left, but I could tell from the top left that could have been like a global map of the epidemiology or something that to really punch that first point out that you made, something like that. But overall, I like the topic. I like that you made a clear emphasis and, you know, MRSA, MSSA, that's really about the antibiotic resistance, not the mortality. And I think you got that across very well. And I think you did a really nice job. I'm impressed.
Thank you.
Great, thank you guys so much. Okay, so moving on, we have our next speaker. Next is Kermit Zhang, Virginia Tech Caroline School of Medicine in Roanoke, Virginia. So Kermit, whenever you are ready to start, go ahead.
Yes, thank you. Delirium is a reversible state of acute confusion that is well recognized as an unwelcome consequence of the ICU environment. Its dangers can be hard to fathom for anyone who has yet to experience it. And for one such patient who did try to put it onto words, she did eloquently say that it felt like it was a huge empty gray space, sort of like a monstrous underground parking garage with no cars, only me, floating or seemingly to float or something. However, I couldn't move at all. I felt my throat and I knew that I had my pipe into my throat, a thick pipe. I could feel the wires and I couldn't move at all. I would get to an edge of something horrible, and once I remember, I thought, if I just let go, then this horror will be over. Estimates suggest that between 30 to 75% of all patients experience at least one delirious episode while they're in the ICU. Moreover, patients who become delirious stay longer in the ICU and are at risk of getting long-term debilitating cognitive degradation like Alzheimer's. We know the unique ICU environment makes certain inherent risk factors precipitants of delirium, and these come from administrations of analgesics, sedatives, and even noise from the supportive equipment that are keeping them alive. At the same time, we understand that these affects their baseline mentative state, and our lab really focuses on the quality of sleep in the ICU that they may be getting. Sleep deprivation, the inability to sleep, poor sleep quality, and altered sleep patterns rank among the top 3 major sources of anxiety and stress during a patient's ICU stay. And they actually have been shown to magnify a patient's overall agitation and perception of their experience, which can ultimately contribute to delirium incidents. As our circadian rhythm, the biological clock that controls our sleep cycle, is intrinsically linked to controlling our sleep patterns, we set out to investigate whether preservation of that rhythm in the hospital can deter the onset of delirium. We did this as a randomized clinical trial where patients were exposed to morning sessions of bright light phototherapy for 30 minutes in the morning to promote maintenance of their sleep-wake patterns. And over the course of our study, we actually saw that patients who did experience delirium had a shortened duration of their episodes, comparatively a 16-hour duration on average compared to 30 hours for those who did not get any light exposure. At the same time, we recognize that patients being admitted to the ICU who are at higher risk of mortality and therefore a greater risk of experiencing delirium appear to benefit from morning phototherapy sessions via a 20% reduction in delirium incidence compared to those who did not. It is that conclusion that has led us to correlate that sleep-wake cycles play a much bigger role in the propagation of delirium than we previously knew, and highlight the importance of not only preserving, but also arguably promoting the most important aspect of recovery in our patients. Thank you.
Great, thanks so much, Kermit. It's an interesting topic. I liked your analogies. And I'm gonna let the judges give their feedback, which is way more important than mine.
Thank you.
Fantastic job, Kermit. I really like the slide. I think that it was very interesting. You did a good job of summarizing the experience of delirium and providing a little bit of perspective for anyone who hasn't seen patients with delirium before or doesn't actually know what the terminology means. So that was excellent. I thought the study that you performed was very interesting. I'm just curious, what was the patient number that was enrolled in the trial?
Yes, we actually ended up enrolling around 85 patients. For our fully powered study, we wanted to have around 110, but because when we were enrolling patients, the pandemic sort of became much more, our hospital pretty much had to be on lockdown, so our trial got suspended. So really our data at this point has around 85-ish patients that I'm sort of briefly summarizing.
Great, that's still good enrollment. I think you did an excellent job.
Thank you.
I can jump in next. So I think you did a very good job. It looked like you sort of had command of all of these stats off the top of your head, which is very impressive. This is a very big problem that probably doesn't get enough attention. I think, tackling it in the way you highlighted it, in the way that your, results clearly impacted how we can think about it, I think is very important, and you captured that well here. In terms of the slide, I think you did a very nice job in terms of, laying it out and making clear sort of what you were tackling. I think, again, as I emphasized previously, it would be nice to have something about the results on here, just in terms of some of the statistics, just so we have something to look at while you're talking about it. And the only other comment I had is I think you spent a long time emphasizing different aspects, clinical aspects of delirium, and that was very helpful for setting the stage. A tie into sleep a little bit earlier on might have helped us focus in on where you were going. We knew because of what, the imagery on the slides, but I think that might have gotten us sort of in the right frame of mind to think about where you were going faster. But really nice work overall.
Thank you.
Yeah, Kermit, I think I'm very interested in delirium, cognitive outcomes. So you're speaking to me directly. I love it, which you didn't know. But anyway, I think all in all, really nice presentation. I think stepwise appropriate, very exciting results. I think impressive to be presenting a randomized controlled trial, which is always cool. For me, I think, again, the results on the slide would have been really helpful just to give me, sort of hone me into what were the exciting results that came out of this. I got a little confused early on because I'm kind of looking at all this stuff, trying to figure out where you're going. And I don't know if you could have predicted that. I think that was just my takeaway, but I think overall, really impressive work, and I liked it a lot.
Okay.
All right, super. Thank you, guys. We're going to move on to our next speaker. We have Niyati Borkar from the North Dakota State University in Fargo, North Dakota. So Niyati, whenever you're ready to start, you can go ahead.
Yeah. Hello, good evening, everyone. Today, almost 1 in 13 adults suffer from asthma, with women accounting nearly 65% of that rate. Asthma is chronic. It can be serious, even life-threatening. It causes your airways to get narrowed and inflamed and makes breathing difficult. Unfortunately, there is no cure for asthma, but it can be managed so you live a normal, healthy life. A lot is happening beneath the surface of what we see in asthma. Did you know that women have a more severe and a higher rate of asthma as compared to men? Lungs are lungs, so can there be differences between men and women because of gender difference? As a matter of fact, boys have higher hospitalization rates due to asthma as compared to girls. After puberty, we women take over and hold that spot. But once we hit menopause, asthma changes again. Why? This is where my research comes into picture. Our bodies are regulated with several reproductive hormones as we grow. The gender switch observed post-puberty, as in the case of asthma, makes it likely that these hormones also influence the functioning of our lungs. Here comes kisspeptin. Kisspeptin is a master hormone critical for the initiation of puberty while also controlling the regulation of all the other sex hormones such as estrogen in females and testosterone in males. But what happens after puberty? Why does asthma switch? And does kisspeptin have anything to do with gender and asthma? To answer these questions, We cultured human airway smooth muscle cells from both male and female asthmatic and non-asthmatic patients and conducted experiments to check the baseline expression of kisspeptins. On the far right of my slide, where you can see the results from our studies indicated a significantly higher expression of kisspeptin in males as compared to females, suggesting a protective role of kisspeptins in men. Surprisingly, the overall expression of kisspeptins was the lowest in asthmatic females, prompting us to consider if it is indeed all about the kiss. Moreover, in vitro administration of kisspeptin also propagated an exaggerated anti-inflammatory response, as in the case of asthmatics. So far, our results from our human studies look promising. Based on our preliminary findings, we are curious to discover the possibility of enhancing the kisspeptins as a future drug therapy, especially for women suffering from asthma. If we can understand how and why asthma behaves differently for men and women, we can use that knowledge to improve asthma care for everyone. Therefore, it's all about the kiss, gender, and asthma. Thank you.
Thank you, Niyati. You had a great energy. I really enjoyed that. Judges, go ahead and give your comments.
All right, I'll jump in first this time. Very nice job. I saw the title and had no idea where we were going, but I was curious right out of the gate, and I think you did a great job sort of walking it all and walking us through it all and putting it together. I think you're highlighting a very important problem here, which is that we cannot keep acting in science as though the only patients are white men, and that's a very important part of where research needs to go, and I think the NIH has recognized that, so keep building on this, and I'm sure people will be handing you money, which is, you know, an important part of doing research. I think the main comment I have for you here, so your slide walks us through everything very nicely. I think emphasizing a little bit more, you have, you know, a nice Western here. Mine never looked like that, so, you know, kudos. But, you know, if you can give us a little bit more on the implications of this, and maybe even a schematic about how the pathway ties together. You give us a little bit in that in the middle column there, but I think otherwise you did a great job setting up your question. You did a great job talking about how you answered it and where to take it from here, and I was very impressed, so good work.
Thank you. Thank you so much.
Yeah,
I will also say, oh, go ahead, Joe. Sorry. So I think you did an excellent job. I thought your slide is very clear, and it helped me to actually flow through the progression and kind of see where we were going in advance. I think it's good that you got your results on the slide, and you definitely sparked my interest in the role of kisspeptin and other sex hormones in asthma pathophysiology. So I think that you did an excellent job. Keep up the good work.
Thank you. Thank you so much.
Yeah, I think really impressive presentation. I think really nice flow to your slide. The only part I got hung up on at the beginning, I think you mentioned kids for a second. And so I had to like frame it twice. Kids have a slightly different prevalence of asthma, and adults have a different prevalence. And I think what I would have done is just focused on your adults instead of trying to, because I ended up getting a little confused right at the beginning, right out of the gate. But after that, I think really nice flow. And I think, again, this kisspeptin hopefully becomes a therapeutic reality.
Thank you.
Okay, so I think we've heard from all of our judges. We're going to move on to our next speaker. So we have Brett Curtis at the University of Pittsburgh School of Medicine in Pennsylvania. So Brett, kick us off whenever you're ready.
Can you guys hear me? Okay, sounds good. All right. Do you remember the story of Goldilocks? Setting aside the criminal trespassing, this parable illustrates the importance.
Wait, Brett, I can't see you though. I can hear you, but I can't see you. Brett?
Hang on.
Thank you, sorry.
No, it's okay.
All right, gotta go back to the beginning.
Can you see me now?
I see something, but not you. I see a book.
Of course. What about now?
Does anybody else? Can anybody else see? I still just see a book. I don't know if you just need to change the angle of your camera.
Of course, the first time that I have trouble with this is during presentation. Hang on.
It's okay. We prefer the video. If we really can't get it to work, we can. You just change.
My front camera isn't working for some strange reason. I don't know why.
Seems like it's just the angle of it. I'm not sure.
Well, for some strange reason, my front and rear camera are both my front camera. So.
Okay. All right. Well, if you're comfortable moving forward without the video, I don't know if anybody else has any suggestions on what to do. We can move forward without the video. I just wanted to jump in before you got too far. So you can go ahead. Thanks so much, Brett.
Sorry, guys.
Nope. Go ahead whenever you're ready.
All right. Now that my thunder has been stolen. Okay, cool. So remember the story of Goldilocks. Setting aside the criminal trespassing, this parable illustrates the importance of just the right amount. In medicine, this indicates that too much of a therapy causes toxicity, while too little means it doesn't work. Just right equals best outcomes. The Goldilocks principle isn't always implemented, like in ICUs where life is tenuous. For example, mechanically ventilated patients receive much more than just right amounts of oxygen. This graph here on the left illustrates why this may occur. Too little oxygen causes hypoxia and even death. However, oxygen too appears to follow the Goldilocks principle, as too much has been linked to toxic free radicals, lung damage, and potentially increased mortality. Yet providers act like just right is actually too much. So to understand this phenomenon, we elicited ICU providers' thoughts on targeting oxygen saturations of 88 to 92% in mechanical ventilation, a just right amount. We conducted semi-structured interviews with respiratory therapists, nurses, and doctors in an ICU in a mixed academic community setting and another in a university hospital. After 29 interviews, we analyzed transcripts with an iterative thematic content analysis approach. We first learned that half of participants did not recognize a state of too much oxygen or its side effects. We then identified important aspects of implementing a just right approach to oxygenation. This facilitated the creation of a conceptual model, as seen here on the right, that illustrates how to change practice from too much oxygen to just right saturations. This process depends on factors in 3 domains: individuals, ICUs, and the implementation process itself. Individual factors included discomfort with lower saturations and concern for patient safety, perceptions that too much oxygen not only lacks harm, but also may be beneficial for patients, and a desire for strong evidence of a just approach to oxygenation. On an ICU level, pre-existing protocols help normalize just right approaches in certain patients, like those with COPD. We also found the implementation of a just right approach must include interprofessional education for buy-in from and education of the entire care team. This helps preempt conflict. In summary, we seem to disregard the Goldilocks principle in mechanical ventilation because of entrenched beliefs. Although consensus is lacking on ICU oxygenation, losing sight of the Goldilocks principle may be deadly if current practice is harmful. Using results from this study, we can adopt a just right approach, whatever it may be, by reflecting on current behaviors and identifying ways to enable change. Ultimately, this could benefit our sickest patients. Thank you.
Thanks so much, Brett. All right, judges, comments.
I feel like we should have worked out an order, team, and just called popcorn or something. But anyway, very nice job. I really liked what you did here. I think the fact that you're honing in on a topic that we can all this is very much in the lived experience of anybody who works in the ICU, I think is great. You really captured the aversion people have to having the oxygen saturation be in the double digits under any circumstances. So I think you did a nice job with that. And I think the graphic on the left is really fantastic. I mean, you did a very nice job sort of putting Goldilocks right in the middle, showing us what the problems are with too much or too little on the sides. My one thought for you on the right side is just try to avoid writing out stuff that you're going to say, just because, if I start reading it off your slides, then I stop listening to you. You could put, individual factors or something like that and maybe have a few keywords. But if you speak the exact wording you have on there, I think it's going to make people zone out a little bit. But I think you did a nice job capturing all the factors. You did a nice job sort of talking us through your intervention and what you plan to do to tackle this. And just as a side note, everybody's been there where there's some AV malfunction when you're getting up to talk, and you did a nice job adapting and recovering and pushing through your talk. So good work. We've all been there. Don't worry about it.
Thank you.
Brett, I think, again, I agree, great recovery, but all in all, nice job. I think you're super enthusiastic about what you're doing. I think your slide complemented your talk very well. I thought it was very clear what you were trying to get across with your slides. The one thing I would caution you is using sort of QI jargon, which I noticed a couple times. For QI folks, no problem. But I did notice, I think, a couple slips there using a little bit of jargon. But other than that, I think really phenomenal work and good job.
Thank you.
And I'll hop in here, Brett. So I thought that was a really engaging presentation. I agree with Bashar that I love the image on the left. I think that you mentioned about half of the professionals not recognizing the concept of the Goldilocks zone. I think that would be something that would be good to include in your results section of the slide, maybe on the right a little bit. And then I will echo again Bashar's thing with the minimizing the text on the right-hand side. But I think that it's a really interesting problem, and you did a really good job of explaining it.
Thank you.
Okay, awesome. Another great presentation. So we have our final speaker for tonight. I just have to do a different screen share. So I have this one as a PDF. So just give me a second to get your slide up, Nicole. Full screen mode. Can't do that. Okay, fine. PDF. Okay. So, can everybody see this slide okay? Okay. Okay, so our final speaker for tonight is Nicole. I feel like I'm going to say your last name wrong. Please correct me. Nicole Buckley from the Ponce School of Medicine in Ponce, Puerto Rico. So whenever you're ready to start, you may begin.
Hello. So what if I told you that there's a chance that all your car accidents aren't really because you're a bad driver, but maybe because you have some undiagnosed sleep obstructive apnea? Well, that was one of the questions we had. This is a little research project that I helped one of the seniors here at Ponce Health Sciences University. So what we did was we grabbed, we had a survey, and what we did, we had 88 over a period of 1 month. We had 88 participants, males and females, from the ages of 21 to 65. They had to have obviously a eligible license to drive. And so they filled out this questionnaire. The questionnaire is called the ESS, which is a Epworth Sleepiness Scale. It is composed of 8 questions that they vary from, that each question varies from 0 to 3 points. So each patient would rank the questions from 0, 1, 2, or 3 points. The scoring goes from 0 to 10 would be like a normal sleepiness. From 11 to 14 would be mild, moderate is 15 to 17, and severe is 18 to 24. So we did this because obstructive sleep apnea, excessive daytime sleepiness is one of the most common symptoms that patients have. And this we found had a correlation with excessive daytime sleepiness when the patients filled out the survey. So what we found out from the Puerto Rican population, because we're here, is that there was an actual correlation that the higher the ESS score, the person's average sleep propensity of their daytime sleepiness, and it actually did have that their more motor vehicle accidents did correlate with the higher ESS value. So the benefits of this, we wanted to create strategies to educate patients to seek early medical attention and treatment to reduce drowsy driving and avoid serious accidents caused by it. So after we conducted this study, we determined that having multiple motor vehicle accidents is directly related to having a higher ESS score, and therefore the subjects may have an increased risk of suffering from obstructive sleep apnea. Thank you.
Thanks, Nicole. It's a fun picture of the guy falling asleep on his coffee cups. Judges, go ahead.
Nicole, I really liked your presentation. I think the flow was logical. I think you're passionate about what you're doing. And I'd be really curious, sort of integrating treatment of sleep apnea and seeing if you can modify these results would be kind of a cool thing to move to next. I think that I like the pictures on the left. I think I would have made them a little bit smaller and included maybe a little bit more on the right with your data potentially. And then I think my only other comment is this written out higher the ESS score. I make that a little bit simpler, and I think it could have conveyed that message a little bit easier. But again, I think good work, nice slide, very easy to follow.
Thank you.
I'll jump in here next if that's okay. Okay, good. So I think you did a very nice job. I think you found a very nice correlation. This is an important issue that you're tackling here, and you clearly know your material and care about it a lot, which you got across well. I agree with Joe that I think maybe making your graphics a little bigger and the pictures a little smaller might have helped, just because you do have a fair amount of white space on the right side that I think you could have occupied. If I can be a nerdy English major for just a moment, I think sometimes when we're writing up our science, we have a tendency to speak as though we are writing as though we are scientists, and we add a lot of extra words that perhaps heretofore we do not need to include. We all do that, and I think sometimes if we just try to make it punchy, we can get our message across more clearly. Here, it's nothing egregious by any means, but is there a correlation between MVA and having undiagnosed OSA? I think could have just been, does undiagnosed OSA cause motor vehicle accidents? Something like that. Just the fewer words, the better. Just make it punchy, make it active so that people don't have to sort of negotiate their way through it. But I think you talked us through it well. You guided us through the logical progression, and you did a very nice job. Good work.
Thank you.
And Nicole, lastly, I'll just say that your presentation was very easy to follow, very clear logical sequence, good presentation style. The one comment for improvement that I would mention is that having acronyms in your slide, especially if you're presenting to a lay audience, may not be the best. So although we all know what MVA stands for, it might be good to actually have that written out if you're going to use it on your slide. And we all know what OSA is, but again, if you're trying to have it for a lay audience, writing that out might be more clear. ESS, Epworth Sleepiness Score, is definitely a lot more of a niche acronym. So having that more clearly defined will be helpful for having it more applicable to a more diverse audience.
Thank you.
Okay, so sounds like we've gone through all of our presentations. I just want to say a few words, and then we have another little few more speakers for the PAR path coming up. But I want to just thank all the students for such engaging presentations. This was such a joy to moderate, so thank you all. I want to direct your attention to the chat box where Andy has posted that People's Choice link. So please go ahead and vote for the speaker that you felt was the most compelling, the most engaging. We want to hear who you think should get acknowledged recognition. I want to remind the judges, if you could email your completed judging scores to me and Katie. Our emails are on the form themselves, so when you're all done kind of inputting your little numbers, send those to us and we'll tally everything up. The People's Choice voting is going to close in about a couple of minutes, so just make sure you get those votes in quick. And then the last thing I want to do is I'm actually going to introduce Donna Appel. She brings so much energy and passion to the MIT committee and to her work, so it's my pleasure to hand this off to Donna, and when she's all done, we're going to reveal the results, the scores for our SPATS winners, so stick around.
Hi, Allison.
Oh, yeah.
Bridget Burns. I'm the senior PAR specialist. Donna, unfortunately, has lost power, so she's unable to be with us tonight. She's asked me to kind of take over for her. So I'm going to just say a few brief words about the Public Advisory Roundtable before I pass it over to our members. Good evening, everyone. My name is Bridget Burns. I'm a senior PARS specialist at the American Thoracic Society. The Public Advisory Roundtable is comprised of 15 patient interest organizations that cross the broad spectrum of critical care, lung, and sleep medicine disorders. And so we have a few presentations tonight. They're just going to give a little bit of information about their organizations and what they can do for you as members. So I'm going to pass this along to Michael Hurley from the Arts Foundation. Michael?
Wonderful. Thank you, Bridget. I appreciate that introduction. My name is Michael Hurley. I am the newest member to the Arts Foundation, but by no means, as you can tell from the title slide, a newly diagnosed ARDS patient or survivor. I was 17 years old in the summer of 2001 when I became ill with pneumonia that progressed into ARDS and was admitted to a pediatric intensive care unit. I spent 60 days on mechanical ventilation. I was deeply sedated. I spent a total of 25 days on ECMO, and I was, chances were not, the odds weren't in my favor, but I did survive. That was the summer before my senior year of high school, and I managed to return to high school for my second semester, complete on time, and start college following year. So going from that to that other extreme was kind of, while celebratory, it was also very much a confusing, upsetting, sort of isolating experience. And I think it's a very poignant topic, what we do at the Arts Foundation, considering the current state of the world. I've read recently about, and Bridget, if you wouldn't mind switching the slide there. So I just want to get into quickly who we are. The Arts Foundation right now, we're just two members. Eileen Rubin, who's the founder, she was diagnosed in 1996 at age 33. She was a prosecuting attorney in the Chicago area and became very ill and got a lot of pushback when she went to the ER, trying to give her Tylenol and send her home. It turns out she had ARDS. She was on mechanical ventilation for several months. So she and I are kind of like the old school arts survivors in the scene. So Eileen has been great. She participates in pretty much all of the day-to-day activities of the foundation. I am, as I said, mentioned, the newest member. So forgive my lack of preparedness here. But you know, it was my experience with ARDS was horrific. It pretty much destroyed my life for a very long time, and I've struggled with PTSD since then. But I've made some tremendous strides in my life, including just working a very high-level job, getting married, traveling the country, living in different cities. I know it makes me sound like kind of a nomad there, but and then, you know, just traveling the world and getting to speak at the 2019 ATS conference in Dallas was a pretty incredible experience. So that's just a little bit about kind of my, the organization's leadership structure. And Bridget, if you wouldn't mind flipping, thanks. So our mission, what do we do? We're here to primarily support and advocate for those who are affected by acute respiratory distress syndrome. When I was discharged from the PICU, I had the most wonderful medical staff, but I felt completely unprepared for the world that I was entering into. I really felt as though I had lost everything. And everyone else seemed cheery, like this was a great day, I'm being discharged. And I had nothing but dread and fear for what would come next, and you know, kind of what challenges I might face, and will I ever walk again, and all these different consuming things. this is from a kid who had not so much of the cavity before this experience. So definitely just came on suddenly and was just one of a very, to this day, I don't have, even my discharge summary says organism unknown. So, I mean, it's like can't be explained right. But primarily what we do is we have outreach events, webinars, Facebook groups, support groups for ARDS survivors, ARDS caretakers, those who are suffering loss from someone who passed from ARDS. There are a number of conferences that we've spoken at, we've had a presence at, and basically we're just a voice for advocacy for patients and survivors of ARDS. We also are very interested in promoting public awareness of ARDS and its effects on not only the ICU experience, but the leaving the ICU and what that means for a person, you know, going through their life, the challenges they may face. So we partner with doctors, medical researchers. We you know, do grant writing activities. We, you know, speak at conferences. We try to promote promote exactly what it is to have ARDS, and sort of share that and let the world know that that is it's a real thing that affects a lot of people. Bridget, I just got one more slide and I'll wrap up here. So our official vision statement is that we seek a world where ARDS is no longer an unknown medical issue and people survive and thrive after being afflicted by ARDS. The ARDS Foundation will be a global force and partner of choice within a worldwide movement dedicated to ending ARDS. We will be known everywhere for our unshakable commitment to the dignity of people. And this is my own personal take on the vision statement. At age 17, I experienced a trauma so consuming and disruptive that my life was split into two components, the before and the after. ARDS destroyed my adolescence, young adulthood, freedom, family, and general ability to feel comfortable and safe. I hope that nobody ever need endure the excruciating pain of ARDS, nor its devastating effects on a survivor's relationships, physical, mental, and emotional health. It leaves survivors with lifelong struggles to make it difficult to think of anything but the worst thing that has ever happened to you. We can do better, so let's please start. So as of July 30th, I am now 19 years out from my experience with ARDS. So that's me, Michael Early, part liaison for the ARDS Foundation, and that is a little bit about the ARDS Foundation.
Thank you. Siri?
Hello, let's see, I've unmuted. I've started my video. Are we good to go?
You're good, Siri.
Okay, I can see. Michael, thank you so much. I just learned so much about that and your personal experience with it. I'm very moved. Thank you. And hello to everyone. I am Siri Vaith, Executive Director of Cystic Fibrosis Research Incorporated, or CFRI. I'm also the mother of a young adult woman who lives with cystic fibrosis. And for those of you who may not know much about cystic fibrosis, or CF, it is the most common fatal genetic disease in the US. It is rare, impacting only 30,000 people in our nation and 70,000 people that we know of worldwide. And due to a mutation in the gene that regulates the CFTR protein, the transfer of fluids between cells is impacted and it causes a dry, thick, sticky mucus that creates problems in virtually every system in the body. Those with CF have progressive lung disease and often have diabetes, sinus disease, pancreatitis, osteoporosis, liver disease, and pancreatic insufficiency. 99% of men with CF are infertile. And the daily medical regimen, just to slow the progression of the disease, can take between 2 and 6 hours per day. Most notably, CF creates a constant state of inflammation in the lungs, in which the thick mucus flattens the cilia in the airway so they cannot be doing their motion, and it prevents clearance of secretions and therefore creates a perfect perfect environment for opportunistic infections. And so while CF is a multi-system disease, the primary cause of death is respiratory failure. And we have been fortunate in our disease state that we've had some great new therapies come down the pipeline. For those born recently, life survival rates are growing, but last year the median age of death was still only 30 years old. So about CFRI, it was founded in 1975. We're celebrating our 45th anniversary. And it was founded by a group of parents whose children were not expected to survive their teen years. And so initially the sole focus was CF research, but we now offer education programs. We just had a massive international conference last weekend, of course, virtually. We also offer psychosocial support and advocacy and awareness programs. Next slide, Bridget, please. Our research program provides awards to CF researchers at medical and academic institutions nationwide. And we fund basic science research that pioneers a new approach to a therapy or cure for CF. And we have two types of awards. The Elizabeth Nash Memorial Fellowship funds CF research by postdoctoral fellows. And these are two-year awards of $60,000 per year. And our New Horizons Awards total $70,000 per year for 2 years, and these are for principal investigators. We don't define the specific area of focus. Next slide, please, Bridget. CFRI's Research Advisory Committee wants to review the best and most innovative new ideas. And so the types and topics, just a few of them, the list goes on and on and on, but the types and topics of recent CFRI-funded research are listed on the slide you can see there, so you can see the diverse range of projects. CFRI is committed to attracting the brightest minds to the field of CF research, and we are cited in hundreds and hundreds of articles for our role in supporting research that has led to some of the most innovative therapy breakthroughs in recent years. And what's great about CFRI funding is that it often serves as seed funding to launch a project, which then attracts funding later as it grows from the CF Foundation and the NIH. We encourage you to focus your energy and intellect in the field of CF research. You can have an impact on advancing science and the push for a cure, thereby providing hope to the thousands of people who struggle daily to survive this challenging disease. Thank you very much.
Thank you, Siri. Jennifer?
Sure. Thank you, Siri. That was really wonderful. I had no idea the breadth of research that you were supporting. Hi, everyone. My name is Jennifer Mefford, and I am the Corporate Relations Director at the Pulmonary Fibrosis Foundation. We are also known as the PFF. And thank you again for this opportunity. I just want to talk a little bit about the foundation and our research program called the Pulmonary Fibrosis Scholars Program. So briefly, the Pulmonary Fibrosis Foundation is the leading patient advocacy organization in the United States dedicated to those living with pulmonary fibrosis. We were founded in the year of 2000, and we are a 501c3 nonprofit organization. So we serve both patient and research community, and we work with a network of experts in pulmonary fibrosis and in interstitial lung disease who provide input into the foundation's research priorities. These include our scientific conference, the PF Scholars Program, and our PFF patient registry. I'm assuming that you have familiarity with pulmonary fibrosis, but if not, I encourage you to visit our website to learn more. I want to share a little bit about our research initiative, the patient registry, which we did begin enrollment in 2016. And this is a resource of real-world longitudinal data that's collected across 42 medical centers and gathered from more than 2,000 patient volunteers. And to date, we've had 17 approved studies from this registry, 6 manuscripts, and 3 publications, including and 1 multi-center NIH-funded research study that's currently underway. Bridget, next slide, please. So the PFF Scholars Program is designed to support early-stage researchers and provide career development opportunities to future leaders in the pulmonary fibrosis field. An award of up to $50,000 is given over a 2-year period to early-stage investigators to support them as they seek K or R level funding. And the PFF supports additional scholarly activities, including supplementary mentorship, by a PFF scholar advisor who's usually a member from our medical advisory board, as well as access to the data that's collected within the patient registry for research purposes. For the upcoming grant cycle, there are 6 awards available. Next slide, Bridget. Great. So this slide illustrates the award cycle. So actually starting this fall in October, our letter of interest begins. And then those that will move on to full proposals will be known by February. And then usually the awards are announced in May following the ATS conference. Next slide, please. So for more information, you may contact me directly. Here's my email address, or you can visit our website, which is pulmonaryfibrosis.org/PFF research. And there you'll find more information about grant specifications. So thank you again for providing me this opportunity. I really appreciate it, and have a great evening.
Thank you, Michelle. Michelle, are you with us? Michelle Mannion from the PCD Foundation is currently having some technical difficulties with her sound, but I encourage everyone to go to our website, thethoracic.org. Under patients, all of our PAR members are listed under there, and you can check out their website. I apologize, Michelle, that you're having some technical difficulties. So we are going to go ahead and go on to our next presenter, Tonya Winders from the Allergy and Asthma Network. Tonya, are you there? Okay, I think we are also missing Tonya today. I apologize everyone for these technical difficulties. We're just going to jump ahead to our next presentation. Marie, are you there, PH Aware?
I am here. Can you hear me?
Yes, I can hear you. Thank you.
All right, great. Hi, everybody. My name is Marie Rand. I am the co-founder and managing director of PH Aware Global Association and the mom of Chloe Rand. PH Aware represents the pulmonary hypertension community. We're a 501c3 nonprofit organization, and we do 2 things. We create global awareness for pulmonary hypertension, and we develop technology for research for the disease. Our goal is to capture, engage, and enable misdiagnosed and undiagnosed PH patients, because early diagnosis and treatment can mean the difference between life and death. We are 3 members. Each of the founding members is the parent of a child who either had or has pulmonary hypertension. My daughter Chloe was diagnosed in 1993 when it was called primary pulmonary hypertension, and we knew very little about the disease. And she ultimately became, at 18 months old, the first person to survive major heart surgery using the first drug in clinical trials. That helped to accelerate the development of Flolan. And my business partner, John Hess's son, was diagnosed when he was 5 years old. At 17 years old, he had after living on Flolan his whole life, he had a bilateral lung transplant. And my business partner, Steve's son, Lucas, was diagnosed when he was 4, and he's on triple combination oral therapy. So for the pulmonary hypertension community, which is abnormally high pressures in your lungs, we represent a very broad range of PH. Starting with Chloe, there were 0 approved medications. There are now 16 approved medications to help better the lives of those who live with PH. And we made a conscious choice to take our for-profit expertise and bring it into a nonprofit world. So we do some things kind of differently and do so by choice. So next slide, please, Bridget. We've established something called the PH Aware Research Network. One of the things that we set out to do at the beginning was to become a self-sustaining nonprofit. So we have developed the something called the Walk, Talk, Track platform, which is the ability to do a 6-minute walk test, which is one of the critical tests that determine how our patients are medicated and also their course of treatment, and also used often in studies. So we have the ability to do a 6-minute walk test on any wearable device, from a handheld phone, iPhone, Android-based, to a wearable iWatch, Android-based, and also Fitbit. So we have, and the other piece of what Walk Talk Tracks does is the ability to do a quality of life survey at any time. We have 2 studies in place right now. The Dynamite is with a physician named Roham Zamanian at Stanford University, and the Quality of Life and WHO study is with the Children's Hospital of Colorado. So over the course of 5 years, we've developed this product. So it has full data privacy protection, multi-facility, multi-study capabilities, supports qualitative and quantitative data, and allows an out-of-clinic research studies for, there we go. You can go to the next one. We can do the next one. So the Walk Talk Track has the ability to collect the following data: heart rate recovery, heart rate variability, chronotropic index, heart rate recovery at 1 minute, gait walk style modification, respiratory rate, incline altitude, humidity, and EKG. It's a very simple device. It's actually end-to-end encrypted, which means nobody sees the data except the researcher or the end user. And we own our own HIPAA-compliant cloud where all of the data lives. So presently, we have been approached since the onset of COVID by many people who who are using a 6-minute walk test as their endpoint in their studies, and they don't want their studies to be halted. So we are now using this device outside of clinic. We've actually matched it with an in-clinic test so that it's very accurate. That's why incline altitude, humidity all got factored in. So that is our one of our technology pieces that we do. And then next slide, please, Bridget. The other thing that we do is we raise global awareness, and we do a huge global outreach program. And we have something called the I'm Aware That I'm Rare, the PH Aware podcast series. 5 years ago, my business partner, Steve, had the idea that he would like to do a podcast series about pulmonary hypertension. We are now, as we entered year 5, I think we're up to 350 episodes. It's downloaded over 20,000 times a month. It's on every platform, as you can see here in the picture. We have our own app. If you have any desire to learn about pulmonary hypertension, this is the best place to do it. We podcast pretty much anybody we can, from patients to caregivers to all of the leading physicians. And we are looking actually for researchers, PhDs, anybody who is doing any work in the PH field, because we are so widely listened to that it really helps our patients better understand their disease and how they can help themselves. So we welcome you to join us if you'd like. You can reach us at info@phaware.global, and we would happily talk to you about anything PH or PH related. So we will do any disease that's connected with pulmonary hypertension as well. And we would love to hear from you. So thank you very much, and have a great night.
Thank you, Marie. Michelle Mannion from the PCD Foundation has tried to log back in. Michelle, is your audio working now?
I think so. Can you hear me?
Oh, yes, it is. I will go back to your
Wonderful. Thank you. I just want to say how much I enjoyed the presentations earlier, too. That was really, really nice to hear all this work that's being done. So I'm Michelle Mannion from the Primary Ciliary Dyskinesia Foundation. PCD you may know it as Carter-Gainer syndrome or remotal cilia syndrome. Like cystic fibrosis, it is a genetic disorder of mucociliary clearance, but instead of affecting the mucus part of the equation, it affects the cilia part of the equation. And the PCD Foundation was started in 2002 to bring some attention to this disorder, to help us to diagnose it, and to finally get research going. Excuse me. And I am the parent of a now 37-year-old with PCD. Next slide. So PCD is a genetic disorder of mucociliary clearance, and it primarily affects the upper and lower airways, including sinuses, ear infections, and frequent pneumonias. It leads to hearing loss, bronchiectasis, and in some cases, respiratory failure and the need for lung transplant. Cilia are also important for organ placement and development, so situs anomalies, including heterotaxy, are common in this disorder. About 50% of the people have some sort of a situs anomaly. Individuals with PCD also have a 200 times increased risk of congenital heart defects. They also experience reproductive health issues because cilia are important both for the movement of flagella and for moving the egg down the fallopian tube. So subfertility is common in women, including ectopic pregnancy. Infertility is common in males. There are hundreds and hundreds of proteins that go to make up just the structure piece of a motile cilia. The estimate is about 500. So far, we know of 50 PCD genes. So it's a complex genetic disorder. Most of these genes are autosomal recessive, but we also have now a dominant gene, and there are some X-linked versions. So lots of room for discovery, genetic discovery, and that's only the structure. We haven't even started looking at function yet of cilia. So there are currently no approved therapies for PCD. So that is our mission, is to get some therapies and improve quality of life. Next slide. So we are a 501c3 tax-exempt organization. Our focus, much like Siri had mentioned earlier, as we're just kind of getting started in this, our focus is on research and accelerating research. And to do this, our main program is called the PATS of Clinical Trials, and it consists of 30+ clinical centers in the US. A lot of our sites overlap with CF because of the similarities in the disorders. And we are also hosting a PCD clinical registry. Probably our most successful partnership has been with the Genetic Disorders of Mucociliary Clearance Consortium, which is an NIH-funded program of the Rare Diseases Clinical Research Network. We also partner with the ATS, which has been one of our strongest and most supportive partners, Gordon conferences, FASEP conferences, and other professional societies that have an interest in PCD. And our reach is global. We are a national organization, but because this is a very rare disease with only about 22,000 people in the US, we do coordinate a lot with our European partners. We provide grant support for conferences and for individual investigators, and this support is both for clinical and basic science research. Often, because our grants are smaller, they're more in the basic science category, but we certainly are open to clinical research as well. I do want to mention that one difference between us and cystic fibrosis is the demographics are a bit different. So there are fewer people in the US with PCD, but worldwide there are 520,000 people with this disorder. So it's the reach is bigger in terms of the overall population, but a little bit smaller in the United States. I think that's it.
Thank you so much, Michelle. And we just have one more. It's going to be a brief audio presentation. Okay.
Hello, my name is Jeff Goldstein. I thank you for allowing me the opportunity to introduce the Lung Transplant Foundation. I'm the president and founding member of the organization. The Lung Transplant Foundation represents the lung transplant community, and our primary objective is to find treatments and therapies for the rejection issues that post-lung transplant patients are subjected to, particularly bronchiolitis obliterans syndrome, or BOS. BOS is an irreversible decline in lung function that can occur after lung transplantation. It occurs in more than 50% of lung transplant recipients within 5 years of lung transplant. There are no known treatments or cures, and it is the leading cause of death for recipients who survive beyond 1 year of post-transplant. Our organization's focus is to improve the lives of lung transplant patients and their families by raising awareness about organ donation, supporting research to improve long-term outcomes, and providing mentoring services for post-lung transplant recipients and their caregivers. We work tirelessly to bring these issues of post-transplant rejection to the forefront through networking and activism with government agencies, pharmaceutical, medical technology companies, and organizations such as the American Thoracic Society and the Patient Public Advisory Roundtable. We are working to make more organs available for lung transplant so to end the shortage and prevent death while waiting for lung transplant. We have two top programs or initiatives the Lung Transplant Foundation works tirelessly for, and that is to provide cutting-edge companies on the forefront of emerging technologies with support, patient advocacy, funding where possible, in order to accelerate the development of therapies and technologies to increase the survival rates for lung transplant. Our second initiative is our Joseph J. Carter Mentorship Program, where we connect patients and their caregivers pre-transplant and post-transplant who are in need of someone who's been through the process to help them with the emotional challenges, the physical challenges, and getting answers that they might not always get from their doctors or might not feel comfortable in asking their doctors or their other healthcare providers for. That's the Lung Transplant Foundation in a quick 3-minute synopsis. We appreciate your listening to our presentation, and we encourage you to think about a lung transplant for your future. Thank you.
Thank you, and that's all the presentations we have today. All of our Public Advisory Roundtable members are listed on our website. If you go under Patients, under PAR, you can see everyone listed. Thank you so much for your time.
Thank you so much, Bridget. That was really great. A lot of powerful stories and a lot of valuable information. We really appreciate that, you guys putting that together. All right, so the moment is here. We're going to announce the winners for the SPATS presentation. So regardless of the results, guys, I want you to know that you all should be commended for your presentations, the excellent work you did, the preparation you put into the execution. You guys did phenomenal. So without further ado, our first place winner is Niyati Borkar. In second place, we have Sophia Levan. In third, we have Brett Curtis. And for our People's Choice, we have a tie between Sophia and Niyati. So thank you guys all again. This was so great. We really enjoyed hearing everybody's presentations. Yes, clap for everybody. And that's it for our SPATS and PARPath session. So a final thanks to everyone.
Thank you.